So we hope you all had a good lunch break. This morning, we talked a lot about medical assistance in dying from both an Islamic and secular point of view. We also talked about sort of the Islamic view of death. The next topic is a heavy one because it discusses the pediatric aspect of palliative care. And we have two very special guests on stage with us to lead the conversation. The first is Imam Ayman Tahir, who is a member of the Canadian Council of Imams. He has been a Khabib and public speaker in Canada since 1997. He has extensive experience working at the Hospital for Sick Children for over the past 27 years. He has also served the community as a chaplain with the Hamilton Police Services. Imam Ayman is also a registered psychotherapist with the College of Registered Psychotherapists of Ontario. He is a member of the Canadian Counselling and Psychotherapy Association, as well as the College of Pastoral Supervision and Psychotherapy. Since working at Sick Kids, Sheikh Ayman has been providing professional psychotherapy and support services through Al Iman Family Services. Our co-speaker for this talk is Dr. Shema Hilal. Dr. Hilal is currently a third-year resident physician in medical genetics and genomics at the University of Toronto. She is also in her third year of her Bachelor's of Islamic Studies at Michigan University. Shema completed her MD at Queen's University as part of their Accelerated Route to Medical School program. Shema has an interest in the intersection of Islam and medicine, particularly from a bioethics perspective and how it pertains to decisions made within genomic medicine.
Assalamu alaikum wa rahmatullahi everybody. So I'm very excited that we're getting to have this conversation as an extension of what's already been discussed today. And it is a heavy topic, talking about children at the end of life. So we will split this topic into a few different categories about what makes end-of-life care for children unique. And if possible, could we just get the slides up? Yeah, so to begin, we do have no disclosures. And then the objective from today's talk is we'll start by discussing the unique challenges of pediatric advanced care planning. We'll understand approaches of pediatric advanced care planning within Islamic law, specifically focusing on fiqh within the four major schools of Sunni Islam. And then we're going to explore the complex interaction between religious, psychosocial, and medical aspects of advanced care planning. So, the big question, why is pediatric end-of-life care unique? What makes the discussion on pediatrics different from the discussion we've already been having on end-of-life care? And there's 6 kind of key things that make children a bit different, or pediatrics a bit different than adults. The first one is prognosis. You've heard lots of conversations today saying that if the prognosis looks futile, or these questions of medical futility, then things that may not have otherwise been aesthetically permissible become aesthetically permissible. But in pediatrics, there's a lot of uncertainty often around the prognosis, and we'll chat about this a bit further. The second one, which is one that's becoming more and more evolving with the advancement of genomic medicine, which is dear to my heart, in medical genetics, which is a lot of times something may be medically futile, but in the next few years, a gene therapy will become available. Something will become available that is a life-changing treatment for this supposedly futile disease, or a disease that doesn't have any currently available treatments. But a lot of parents and families will hold on to that hope, and that uncertainty also makes pediatrics a bit unique. The second one is children don't make decisions for themselves, and so consent and autonomy concerns often come up, more so in pediatrics than adults, because families are the ones making the decisions. The patient themselves is often unable to speak for themselves, and so this makes it a bit challenging to understand both consent and autonomy from both a medical perspective, a medical ethics perspective, as well as an Islamic ethics perspective. The bereavement process for a lost child is a lot different. Post-mortem autopsy comes up in adults as well, but specifically a unique consideration for pediatric populations. And of course, when a child dies, it doesn't end there. We're often thinking, what are the implications for the family? What are the implications for everybody else involved? I have to say, pediatric death is only the start of another whole new care process. And so we'll move on to the first part of this talk, which is prognostication on pediatrics. I wanted to start with this question, which I find always interesting. What kills, why do children die? Why do people think that, or what do you guys think are the leading causes of death among children? You can throw out some answers. Trauma. Trauma's the number one. Anything else? Cancer. And then the third one. Let's go. You guys are doing great. You're in order so far. I can see two things. Congenital. Okay, Dr. Amatarashi clearly is an expert now on pediatric causes of death because those are exactly the top three. And so this is actually, I collaborated this, I got this from the Canadian Census website. And so, yeah, the number one leading cause of death among children is accidents or unintentional injuries. The leading up to this in this group is actually motor vehicle incidents. The second is malignant neoplasms. And the third one is congenital malformations. This is dear to my heart, and we'll chat about this category because it's often the one that has more prognostic difficulties. The fourth is actually intentional self-harm or suicide. The fifth being respiratory illness, influenza, pneumonia, COVID-19. So seven peaked in the last between 2021 and 2022, but I would say kind of category in the same category: respiratory illnesses, diseases of the heart, homicide or assault, or intentional injury, and then perinatal insults. And so just a little bit more on pediatric death from a medical perspective. Most pediatric death does occur in hospital. Children rarely die out of hospital. Usually it's within the intensive care unit, the pediatric intensive care unit or the PICU. Estimates vary, but this one's really interesting. Usually when children die, it's not like so-called natural. It's usually due to withdrawal of life support. So over half is the general prediction. 40 to 75 to 70% of deaths in the pediatric population only occur after withdrawal of life-sustaining measures. And the time of death following withdrawal of life support or life-sustaining measures is very variable. And in the literature, this time is considered a very difficult time because parents are expecting their child to die right away after withdrawing life support, after withdrawing respiratory supports, but this doesn't always happen. Usually there's about an hour delay and oftentimes longer as well. And then a little bit more. This one is where I find it very interesting from the prognostication perspective. So there's two sort of studies that I found, and these are just a surrogate for what exists beyond the literature. But how good are we actually at prognosticating pediatric death? And here's the answer. It depends on who's prognosticating. Pediatricians tend to be optimistic. Intensive care unit staffs tend to be conservative. And so they're both generally have about the same incorrect estimate rates, both of the times. So pediatricians, when a child comes into hospital, they're admitted to a pediatric unit, about 1% of the time, a pediatrician will have told them your child's stable and they can stay on the ward, and that child will end up in the ICU, and about 38% of those in one study required critical care interventions within the first 72 hours. These are families that were expecting their child just had a bit of a cold, and suddenly they require some sort of respiratory support and ended in the ICU. Happens about 1% of the time. So 1 in 100 children are prognosticated sort of over-optimistic. And on the other hand, in the ICU setting, this was really interesting. Attending physicians were the best, but they still over-predicted mortality. So they would over-predict mortality in about 6% of cases when it was usually around 5.5%. Residents and fellows within the ICU were even more conservative, and their rates were further apart from the mortality rate predictions. Nurses were predicting mortality rates up to 1 in 7, 1 in 8, and they were only closer to 1 in 20. So as you can see, with the ICU setting, they tend to be a little bit less certain, and that's because children, when they end up in the ICU, can be really, really sick, but they can also turn a corner really, really quickly. And then, of course, this next part of the talk, patients are always waiting. I found this, this was published recently by a family, and it was a family that found that their child had a condition called AADC deficiency. This has come in the media a lot recently, but there is now a gene therapy available on a research basis, and so a lot of families now will wait until the next trial comes out and hold on to a kid that they're picking for as long as possible. And this is the one phrase that I found was interesting. She said during that time, it was crucial to keep her daughter healthy and eligible for the surgery. So these are children who are very, very often very sick, often require respiratory supports, and patients and parents will try to keep their children in the ICU for as long as possible, because once they receive that gene therapy, it can be life-changing, and they can actually regain total motor control. Now I'm going to hand it over to Sheikh Ayman to talk about, from an Islamic perspective, when we're talking about pediatric resuscitation and withdrawal of life support, what is the fiqh rule
dealing with the pediatric population is completely unique than dealing with the adult population, simply for the fact that children are more dear to their loved ones, and they're not the one who will be taking the decision making in the process of their treatment or the end of life. So that process is very delicate and complicated, that involves so many dimensions. And from my practice in the hospital for kids with kids population has been always looking into what's behind the issues that the families come to me with. The issues of growing life support is normally presented to the families by the medical team. As Dr. Sharma mentioned that most of the time the ICUs doctors intend to be more conservative in their prognosis and with their approach with the families, just to get themselves off the hook and to be not liable for anything further if any complications happen to the child, or at the same time not to disappoint the families. Now, here comes the problem. The medical team is very conservative in their approach. The family has high expectations from their end. And at the same time, we are seeing now families who are attached to their child, trying to be the advocate for their children and deal with, and be there for them in those vulnerable time in their lifespan. And keep in mind the emotional attachment. Now, we will go through the details of the fiqh perspective on the growing life support with different madahib. But keep in mind for those who are practicing in medical settings, that the Muslim population is very diverse in their approach of the Islamic practice. There are those who are very observant to those who are not observant at all. And there are those in between. Now, when it comes to the decision-making process, this decision-making process is shaped to a certain extent with the way this family is observing to their own faith. And whether they're going to be going with the Hanbali or the Shafi'i or the Hanafi is irrelevant, because for them, they're not an expert in the fiqh perspective, nor they're an expert in the medical field. But what they most of the time come for is to find an easy way for them to accept this very heavy process in the treatment process or the end of life of their own loved one. So most of them are familiar with the fiqh perspective. They have no problems with it because they read it on the internet. But the interpretation of that into their life is a real problem. And finding someone who can walk them through this process or decision-making process is very important. And they always look for someone to provide us with the guidance, but at the same time to help them walk out of the hospital doors, not feeling that they haven't done what needs to be done, or they would be avoiding the guilt feelings later on as they take a decision-making, in the critical decision-making in the life of their own child or the end of life of their own child. So with this, inshallah, we go to the next slide. As you can see that throughout the school of thoughts, we pay a lot of weight and value to the life in general, and we only allow or permit the end of life to happen by growing the life support, which is, by the way, I always try to explain to families that what you see from the gadgets and the medical team are all means a step into the love of Allah. This is how we can reframe things into the right perspective. As it was already been mentioned, mashallah, in the previous presentation, how the difference between the Western perspective of medicine to the Muslim perspective of medicine is that we always connect things to Allah Azza wa Jalla, and we put things into the right perspective, unlike the secular perspective, which is based, which is what's based on the medical, or the Western perspective of medicine. So in general, all schools of thought agree that the withdrawal of life support can be permissible if the treatment is futile, and only prolongs the child's suffering, and also they focus on the allowing of natural death without causing it, and emphasizing that the treatment do not provide accurate benefit and can be discontinued. As you can see, this is basic logical things that what the fiqh is presenting to us. But again, part of this whole process. The decision making to enroll the life support is allowed under certain circumstances. If continuing the treatment provide no benefit, but only prolongs the dying process, scholars may permit the withdrawal. However, basic care like hydration and nutrition should continue unless it causes harm. And this is the thing in the Shafi. I think we missed that one from. We missed there's one school for that, I think. Hanafi, yes. So, yeah, I don't think we got to the Hanafi. Oh, but we got the Hanafi. I'm sorry. We go now. The next one is the Maliki. Now, if we go back to the Maliki, this, however, the basic care like hydration and nutrition should continue unless it causes harm. This is, by the way, from my experience, is a very critical point. When you come to families, so to say to them, okay, well, there's no point. Let's just go ahead and withdraw life support. And we're going to be taking also, behind the nutrition from the child. This by itself would make parents feel that they're killing their own child. They would feel that it's like, I can't. And I've heard it even from some of the doctors, Muslim doctors in the hospital. I recall Allah, Ahmad Qibi, who was he was my mentor when my journey of working in the hospital. And I also consulted him. I said, no, Shaykh, I won't agree with this. That nutrition continue, because you cannot withdraw the nutrition on the child and cause a disturbance. Now, from the palliative care perspective, I've been involved very much with the palliative care team. They say, there's no harm, because after a certain time, patients would not feel the hunger or would not feel the pain of being dehydrated or losing weight as they're moving on. Again, two different perspectives, one secular perspective and one Islamic perspective, and one emotional perspective coming from the family. So, which way were we going? We were using the Hanafi madhab, the Maliki madhab, or the Hanbali madhab. Is all based on what the family themselves would deem to be most effective or more, satisfying to their own conscience and Islamic beliefs. So we can go now to the next one, which is I think the Shafi'i school of thought. It permits the removal of the life supporting treatment in cases with no hope of recovery, emphasizing the principle of preventing harm. Again, it's the preventing harm versus preserving life or keeping a person on life support for a long time, particularly if life support causes further suffering. Now, some of you know aware of some other faith backgrounds. They would not withdraw life support as long as the person's heart is pumping, for instance. Now, for us, without going into the details of what are the signs of death, there are certain signs of death. Among them, the top of them is the damage of the brain. Once the brain is damaged, the mechanical process of the heart pumping and different other signs with the life support is not going to be causing any treatment or recovering the patient from what they're suffering or dealing with. So there's no point for doing that. And we just honor the person at the end of the journey of the end of their life and give the rest in peace into the hereafter. They stress, let me just go to the last point. They stress that this is not an act of euthanasia. So this is very important, because most of the time, and as I said again, I'm just saying to people who are going to be in the medical field, and most likely we have Muslims and Muslim majority are Muslims, but I know there will be non-Muslims who are trying to benefit from this and know how to deal with Muslim patients. The first thing comes from the Muslim family. I'm not going to be ending the life of my own child. You're not causing the end of your life, the life of your child. You're not exercising euthanasia. Euthanasia is absolutely unacceptable in our practice as Muslim. But so from the Shafi'i madhab, this is not an act of euthanasia. Now, the Hanbali, which is going to be very strict in their approach, they also support withdrawing life support if the experts conclude that treatment is futile and only prolongs suffering, but they emphasize the continuation of basic care until it leads to a greater harm. Again, to provide the nutrition to the patient, life support, or whether to withdraw it. Again, in my overall years of practice, I've come to the conclusion: do not stop feeding, but withdraw the life support, or do not DNR, which is do not cases they're in, complicated situation where families would not feel that they have contributed, but they will leave it to the nature, process of death and leave it to Allah Azza wa Jalla. Now, this is most likely, so as we can see from reviewing all the, madahib perspective into this issue, that Islamic scholars stress that the decision should be made with the guidance of medical expertise. This is number one. So most of the time, medical guys come to me, they're feeling helpless, or the families come to me, I say, okay, we cannot make a decision unless we get the expertise of all who are the medical doctors. We will take their opinion as professional medical doctors, not as experts in the medical field. And this has been sometimes a bit problematic for me. Some of the medical team, whether the doctors or nurses or other disciplines, would be familiar with Muslim practice, and they come to the family and try to pretend that they're familiar, and they try to push them or persuade them in a certain direction. I tell them, hold on, you cannot do it. You are not a fit for them to accept from you. Otherwise, as a matter of fact, if you try to impose on them something, this could be causing a reverse reaction to them. So leave it to the expert, leave it to those who are dealing, because when comes to Muslim families, they would be trusting a Muslim doctor, they would be trusting an imam or a chaplain, and they would feel comfortable with it. But when someone with other faith background, with whatever profession or discipline they have, they would probably have difficulties to accept what they're posing on them. So now, leave it to the experts, and now again, in a nutshell, the decision-making process should be involved doctors, religious figures, and consultation would be to balance physical realities and spiritual responsibilities. And this is very important. Just as I'm concluding, inshallah, my slides, it's also very important to consider reaching out for the right Islamic resource, because with all respect to an imam, and I say to the imams also in our meetings, if you're not trained in medical settings to deal with medical issues or ethics of the medical practices, or if not a psychotherapist, do not attempt to be doing things that you are not an expert in, because you could be causing harm rather than causing benefit to the family or to the people. Stick with your practice or your expertise, and let someone else be able to do that. So there has been a lot of cases. I'm sure we have a couple of cases whereby we can extend this also.
Before I switch this, inshallah ta'ala, so we'll chat about a little bit of a case, and we'll kind of go back and forth and hear your thoughts as well, inshallah. So earlier I showed you guys some slides which essentially showed that more than half of the time what we're doing when a child dies is because we withdrew life support. Children don't really die naturally, so to speak, and that becomes really hard because from two perspectives. From the perspective of a clinician, prognostication is really difficult, and it's equal on both sides. 1% of the time we get it wrong, we're over-ambitious, we're over-optimistic. And 1% of the time, we are overly conservative. And I'll give you a common scenario that we see, especially now, and of course I'm a genomics, so there's always going to be a genomic flavor to this, because I think genomic medicine has really complicated the story for pediatrics. But a child's born in the NICU, perhaps premature, perhaps with a lot of very complex medical history, or a complicated birth history, traumatic birth, and now they're admitted to the NICU. They're on very high ventilator settings. They're on an FiO2 requiring oxygen in the 70%. They're hypotonic, severely hypotonic, meaning that their muscles are very floppy, because those are not in medicine. And on top of that, the baby's not making any spontaneous movements. What happens, and this is a very common situation in sick kids. Of course, the team is not sure what to do. This baby was just born, and we're not sure how long to wait. Then comes along what we call the new advent of genomic medicine, and people want a diagnosis. Because then it gives us something to hold on to, some information to tell the family, otherwise the family's in a black box, not knowing what to do next. Perhaps they do genomic medicine and they find out there's a diagnosis of some congenital myopathy, and everything makes sense. This child is weak from head to toe. And now the family's in the NICU, and they have to make a decision. Are they going to withdraw life support or not? And I recall, as a trainee, when I first started in medicine, in genetics, I felt when I received or would get like a genetic diagnosis for a family, I felt the need to tell them everything. So I would come day one with my what we call a disclosure, and this is where we give them prognostication information. And I'd be according to the literature, there's one kid who lived until 4 months and he died really bad from a respiratory infection. Another kid lived to 6 years, died really bad from respiratory infection, right? And then the neurologist will come and say, but I believe there is a gene therapy coming and maybe something will happen and we will have some gene that can change this congenital myopathy and maybe your child won't be like the literature. But everything in the literature is looking bleak and grim, and the PICU is putting pressure on you because they're not seeing any spontaneous movements, that they want this child withdrawn from life support because it's traumatic for the family, yet they want to hold on to this hope. And there's nothing, you have no previous history, you have nothing from this child to give you any indication about whether or not they're going to improve, are they going to be a very severe case, a mild case, and as you'll know with any genetic change, there can be a spectrum. And so you don't know where this child's going to lie, and you're sitting there against the table, and the family asks you the very simple question, what would you do to the physician? And I pose this to you guys first in the table, would you decide to be an optimistic doctor who says, let's wait, let's do everything, quote unquote, do everything, which is wait, or do you take the more conservative approach and tell the family, I'm not seeing any movements, I'm not seeing any spontaneous respirations, the literature looks grim, at the best, even if the child makes it out of the NICU, they're likely to die from a bad respiratory infection earlier in the neonatal period or in the pediatric period. And then these patients, then what we do in this case is we consult Sheikh Ayman, when the Muslim is Muslim. And then they come and they have a conversation with Sheikh Ayman and they're telling him, we don't know what to do. And so what is the conversation like on your side?
Well, again, see, when I deal with families, or when family reach out for help, we're trying to deal with the psycho, social, spiritual dimension of the problem. Now, the medical perspective of the problem is presented by the doctors. Should the doctors be giving too much hope or giving conservative hope? That's a different question. The family are not too familiar with what the doctors say. They speak to them different language right away, even though they can interact with them. But in reality, they're just listening to a foreign language. They don't understand the diagnosis proper way. You told them, you told them that, okay, sure, they get it from you, but they're looking at their child. One day the child is doing very well, is interacting, maybe opening the eyes, showing signs of interaction with the family build a whole, alhamdulillah, a miracle is happening. Now, the next day, the child goes, the conditions goes dying, and then things are not, that good, and then eventually families start doubting their hope. Now, again, what the family is looking for is to deal with this psychosocial spiritual damage. Number one, I want to make sure that I'm not causing an harm to my child. I want to make sure that I'm standing for my child in a critical condition in their lifespan. At the same time, I don't want to be violating the principles of my belief. And at the same time, after all this is finished, whether it's the recovery of my child or the end of life of my child, I want to walk away from the hospital not feeling guilty or potentially feel guilty afterwards. So when I sat with them, I would just explore all these dimensions, look into all these things, hear them out of what their concerns are really about. Most of them have gone online and read what the diagnosis is all about, medical perspective, and they have read the fatwa online, but they're unable to understand the connection. They're unable to digest what that is. So there comes, the expertise of people like myself to come in and walk them through this journey and help them to easily accept the fact your child is really sick. He's not going to be able to make it. Yes, one day you'll be seeing him showing, signs of recovery, but other day he's not. But when we look into the medical side of it, clearly the child is not going to make it because there's multiple organ failure. There's something that is seriously happening with the child, or the cancer is spread all over the body. There's no way that from a human perspective that this child is going to survive. So there's no point for building so much hope. But at the same time, look, it's the family. They're looking for a miracle. Can we deny that from them? No, we cannot. So what we can do is we strike a balance between them and say, do whatever we're able to as a human being, and leave this to Allah, to the mighty Allah.
In these circumstances, I've actually found, especially with my Muslim families, I'll come in and I will very clearly say, there's a very sick child who, let's say they made it out of the initial PICU setting, and now I'm seeing them on the ward, and they're back again. Another respiratory illness, they're back again. Another respiratory illness, and each time the FiO2 keeps going up, and maybe they get off the high floor this time, maybe they don't. And maybe it's a prolonged admission this time, maybe it's not. And this is where it gets really complicated. What I've learned to do now, and this has been truly life-changing, is I come in and I sit down and I look at that family and I say, I don't know. I don't know what's going to happen. I'm going to do my best to learn about your child, learn what's going on with their condition, and offer you everything I can available. But at the end of the day, it's your decision if you feel like you want to continue. Like some families will say, the thought of having a very disabled child is not acceptable to them. They don't think that's a quality of life. And other families will say, even if my child can just breathe, that's a quality of life. And that's a very personalized decision. And again, today I tell them to remove the guilt, that both decisions are aesthetically permissible. You will be rewarded for the fact that you want to keep your child alive, even though all he's doing is breathing, but you also will be rewarded for not wanting your child to punish, to suffer and be extremist and be, not have a quality of life. So I tell them, both decisions, you're not a bad Muslim either way. Right? And so really taking that onus off of them and telling them that we're here to support you in whichever way possible, from a both spiritual and psychosocial perspective. And the second I say that, I can tell you 99% of the time, the families immediately switch from being very, angry at the medical team and more accepting, because now they at the end of the day, it's a lot of times, I would say, they have so much guilt and fear that they're going to make the wrong decision for their baby, their child. And you just have to let them know whichever decision they make is because they're Muslim, their intentions in the right place, and that this decision is valid and fair regardless of which way they choose to proceed. And this is why it becomes really important to involve spiritual care early on, because families just need to come to accept that. Right? They almost in their heart already know what they want to do, but they just need someone to give them permission that doing whatever it is, be it keep a child that's very disabled, you're not a bad parent who wants your child to suffer, or keep a child, or choose to withdraw care for a child who has a bleak prognosis, you're not a bad Muslim for wanting to quote-unquote kill your child, is what they need to process. They have the decision made, they just need someone to help them kind of go through that, the guilt, the psychosocial aspect, and let them know that aesthetically there is a basis for both of them. And this becomes true in a lot of aspects.
Just to add on the top of what you said, in this context, what we need to do is help the family to understand the context of what they're going through within the Islamic perspective. And now I'm just saying this to the patients and helping to understand where they come from. In the medical team used very technical terms, like what was presented in the beginning. They used the technical terms in terms of the probability of life is this much. They deal with patients as they're dealing with the mechanic deals with the broken car and the possibility and the diagnosis and the fixing problem. This is what the term is used most of the time. I try to all the time reframe things. What you see around you from machines and medical team are only tools. That's not the ultimate cause for life, and it is and that's Allah Azza wa Jalla. So once you reframe things into the right perspective and help them to understand that yes, you're doing your job, they're doing their job as a medical team, trying to do whatever they have in their abilities and expertise, but it's ultimately up to Allah. فإذا جاء أجلهم لا يستأخرون ساعة ولا يستقدمون. خلاص, done deal. And if your end is not there, no one can end it, no one can prevent it. So we need to just put things into right perspective and help them to understand that, so they can live in peace of mind.
Absolutely. And one final comment I'll share an anecdote. Again, when I started residency, I was very conservative because I didn't like giving people false hope. I thought it was cruel, and I thought if they had to suffer, then it was my responsibility as a physician to tell them everything fairly and honestly, otherwise I was being dishonest. So on one of these days when I had a disclosure, which I was disclosing essentially to the mother a diagnosis of basically a skeletal dysplasia, which typically has early pediatric death within 6 to 7 years of age. I was sitting and I was telling her everything very honestly. I was like, this is the situation, this is what the child has, it probably won't live until 6 years old, this is your options, if you wanted to, you could do this, this, and this. And then I showed her some images of children with this condition, showed her some examples. She just stopped and broke down and said, "Irhamini." She said, "Have mercy on me." And I really stopped and I thought to myself, was it absolutely necessary? I felt dishonest because in a way I was like, I'm being dishonest by not telling them everything they need to know about this condition because they need to make an informed decision. But at the same time, there was no mercy in sitting there with her and just showing her the horrid, reality of what she would be going through. And since then, I remember speaking to other Muslims about this, physicians, non-Muslim physicians. They said, you're not withholding information, not being patronizing by deciding selectively which information to share and when. Prognostication conversations don't need to be a one-time conversation. You don't need to share and be honest with someone the first time you meet them. And that's always stuck with me since then. And I think the rahmah, I But I think finding that balance as a clinician is really challenging, and it's something we always have to kind of grapple with, because at the end of the day, there is always uncertainty about what we're saying, and we have to be honest about that, even with ourselves.
Before you move on to the next slide, one piece I'm not sure if it fits right now or maybe in the next slides, but we also have to keep in mind that the medical team are human beings with feelings, and they build attachment with the child similar to the attachment that the parents most of the time would have. Not close to, but at least there is an attachment. So that means they will feel that they're obligated, their human, nature will push them to react and do something. Now, their perspective, again, from whatever cultural or faith background they have, will be projected into that. So that's something to keep in mind also in the decision-making process, but at the same time to keep in mind that the medical team also needs to be acknowledged for their own feelings and their own suffering, because there is a bit of suffering from the medical team as well. And this is how I hope that is paid attention to by the admin of the hospital, whereby they get more into the care of the physician and the staff, and provide support for them that is needed.
Absolutely, inshallah. And the next few sections are shorter, inshallah, but the next topic is really about consent and autonomy. I thought to frame this, we'll just go straight into a case. So this was published in the American Association of Pediatrics Journal by Dr. Asim Padala and a few of his colleagues. So this was a 2-month-old baby who was found unresponsive in his crib after his mother heard him choke shortly after feeding. Parents drove him to the emergency department. He was apneic, he was pulseless. ROS and ROSC was achieved after 30 minutes of CPR, which happens often. You can achieve ROSC in kids. Adults are so shocked by this. But yes, you can get repeated or return to spontaneous circulation. And someone who dies at home and comes to the hospital. Kids are amazing, but they're coming with their physiology. He's transferred to the PICU. On physical exam, the child has intermittent respiratory effort over the ventilator, no withdrawal from painful stimuli, no pupillary response to light. And over the next few days, his neurological exam remained limited to just intermittent seizures and irregular respiratory effort, no other signs of brainstem function on serial examination. And additionally, here the brain MRI looked like diffuse axonal injury, including diffuse injury to the brainstem. And so the parents, this is actually taken directly from the paper, which I thought was interesting to see. The parents are young and had recently immigrated from Saudi Arabia. The mother is wearing a full black burqa, exposing only her face. She speaks no English. The father is wearing a t-shirt and jeans and speaks fluent English. A meeting is scheduled. Both parents, the neurologist, social workers, PQ team, and an Arabic interpreter to discuss the prognosis and plans. Before the day of the meeting, the father meets alone with the attending physician. He tells her that he understands his son's dire condition and weak prognosis and asks the physician to discontinue the ventilator and let his son die, but not his wife, that they stopped the ventilator. She will, he says, accept the fact that the boy has died, but knowing that AFib would be devastating to her, is it permissible to stop the ventilator in this case after discussing it with the father? Before we go into this case, I want you to think about this. I want to talk about from a code of ethics perspective what we know about things like this. And so the AMA, when it comes to withholding information from a parent or child, they say parents in all custody and guardianship have equal access to information and decision making for their child, and they also encourage for the inclusion of the child who's a minor who can understand when possible. The CMA interestingly says if a minor does not have capacity, consent must be obtained from the parent or guardian of the child, but does not specify that both parents need to provide that consent. In fact, unanimously across pediatric hospitals will agree if you have consent from one parent and you just never met the other parent, that's sufficient to make a decision. Because maybe that other parent is busy, etc. We don't necessarily always go out of our way to hear the perspective of both parents. Because as long as one adult is there, you can typically make a decision from that one adult. And then again, respecting the autonomy of minors. That's from a medical ethics perspective, like a Western medical ethics perspective. From an Islamic ethics perspective, shared decision making or shura, or consultation, is the preferred model of Islamic household. From the shura itself, it discusses Allah subhanahu wa ta'ala praises those who advise in consultation or take consultation. But of course, fathers are also aware, and women are similar to men in rights, but fathers do have a degree of responsibility to make that final decision. Okay, so now you have to consider both of these different aspects, and I'll take a bit of a poll before I tell you how they proceeded. Maybe Shahani can also provide your thoughts on this one. How would you guys proceed in this case? A is consent only needs to be obtained by one parent legally, so the father's authority should be respected. He follows an ethical framework different to that to Western ethics, so we should respect his decision and withdraw like care support without informing the mom. The B is the father and mother both need to consent to withdrawal of care, as shared decision making is the Islamic model. It's also the more ethical model, so we should hear from both of them, and both of them should have to make a decision. Or C is the mother has a right to know about the status of the child, but ultimately withdrawal of care consent only needs to be obtained from one parent. Who says A? So nobody's comfortable withdrawing support without at least hearing from the mom. Who says B? You want to hear from both parents, and you want them both to make a decision. And who says C? The mother has a right to know, but ultimately you could make a decision just from the father's perspective. That's what was done in this situation. You can provide your thoughts.
Okay, just again, put things in the right perspective. No, in therapy, we always look into the cultural context of what we're dealing with. In this situation here, we have a mom who's coming from Saudi Arabia, and she is not familiar with the Western context of the medical practice. The dad was quite the opposite, was more familiar. So I bet you on some money that dad was able to understand more from the medical team what are the details and diagnosis of the child's condition and how critical a dire is. However, for him to be playing the role of al-Qawwam, meaning to say he's the one who's protecting the family, does not necessarily mean he's dictating what goes into the family. He's exercising his role as being the protector to the family members, including the mom, who's going in a very critical and very challenging circumstance. She's paralyzed emotionally. She's numb. She's in so much pain, and she is unable to think clearly, especially in the context of what she's dealing with. She's dealing with the cultural shock of being coming from one culture to another culture, and now dealing with the sickness of her child. And the father is trying to play the role of the person who is trying to save and protect the family. So that has been said. I am in complete compliance and agreement that mom should be in the picture no matter what, because she is I always say that in another context. No matter how much dad are able to connect with children, they're unable to connect like the moms. So there's something unique between the children and their mothers. And this is mentioned in the Quran even. So we cannot separate that. So you need to give mom the ability to absorb, digest, and connect with this end of life process and be there present and take not a full lead at least be involved in that process, so that the end of life would be done in a more humane, more will give the closure that is mom need for her to let go of her attachment with the baby.
Yeah. So the beautifully as Sheikh Evan has said is that the big issue with withdrawal of support, the first option, without the mom's knowledge or consent, is she wouldn't even know when the baby would be withdrawing the support, and she wouldn't have that chance to sit and hold her child one last time, which is really important. I always tell parents, even if they're going through a lot of times people say, I don't want to know when withdrawing life support, I don't want to be there. I hear this often, and I'll tell them, think again. The literature always shows holding your baby for that one last time is actually a very critical moment in that closure. Otherwise, there's a lot of regret people have later on in life. Like, I wasn't there for the last moments of my child's life, and I'm the one who asked them to pull the plug. And so, from that perspective, they thought from a mercy to the mom's perspective, she at least had the right to understand the full prognosis of the child. But if she still remained silent and didn't feel that she even wanted to speak or offer her consent, because maybe to her that felt like saying she was okay with killing her child, then it would be okay and actually be merciful, it would actually be more kind and understanding to the family to just take the consent from the father. And that's what they ultimately did. The medical team felt very uncomfortable with it. They sat down, had a conversation with both the mom and the father, explained the full prognosis, explained the recommendation for withdrawal of life care support, and the mother had remained silent. She didn't want to speak, she didn't want to say anything, she didn't want to offer her opinion. The father thanked the team and said, please withdraw life support. My wife does not want to be there this evening. The medical team did feel very uncomfortable and said, we really want to hear something from her, but that is just our own discomfort. That we feel like we want to hear from both parents, but at the end of the day, even from a code of ethics perspective, you only need consent from one parent. The information was provided to her, and so this was the decision to withdraw life support after providing the full information to the mom, but not necessarily needing her explicit consent. And then we'll move on to sort of the bereavement process when a child has died. It's very different. I always share this story because I want people to appreciate the difference in kids and adults. When a child dies, I actually have a list of all the children that have ever passed away that I've taken care care of or been involved in their care, every few months I'll call and check in on the families. When I was on my internal medicine rotation, because I needed to go through, I thought that would be a great idea to do. So my first internal medicine death was an older woman in her 90s. She died of some CHF exaggeration. Called her daughter a few weeks later. After meeting her, of course, at the time of the death, I actually wrote the death certificate for her mom. And so I was asking how she's doing. She looked at me very, like, not well, but like, told me very strangely. I was like, my mom, she died like 2 weeks ago. Why are you calling me? And I was like, oh, that's not usually the response I get from parents. And this shows you how complex the bereavement process is, for children. I've never called a family in PD even 6 or 7 months later, except that they're so grateful and gracious that you're calling them and still grieving that lost child. And so there's different, ways they can get through this, but I think it's really, this is where spiritual care becomes important. We don't always have the time as clinicians to really sit down with the families and help them through that bereavement process. But these different ahadith tend to be things that I'll quote or cite to give parents comfort. And I'll let you take over, Shaitan, and how you speak with parents in regards to this.
I remember, I would say 25 years ago at least. I'm not that old right now, I'm still young. I was in a workshop setting where different discipline individuals, and we were just talking about how we deal with things in the hospital. And I said to them, I help people make sense of the nonsense in their life. Because really, what would you be saying to a mom who's losing her child, or to a father who's been back and forth to the hospital after long suffering, end up losing their own child, a loved one. And there's no rational justification or explanation for that, except if you look at it from the right perspective. If you look at it from the right perspective, yes indeed. Allah Azza said that death is explained as a tragedy in our tradition. But at the same time, Allah Azza He's created death and life. He will test you, see how long you will be reacting in a positive way. And at the same time, we're tested with things that we love. As I said earlier, the attachment between parents and child is amazing. That's why we care for our children. After all, if there's no rahmah, there's no attachment, we won't care about our children. But now, when that thing happened, when death happened, we're hit hard, we're tested with the things that we love the dearest to our hearts. So we need to explain to families as they grieve is that this is something that Allah has chosen first of all for them, and this is for their own benefit. And after all, this is not the end of it. You lost your child now, but you will be reuniting with them in the hereafter. And to reunite with them in the hereafter, you need to be in the right path, and to understand the concept that that they will be tested and loved by Allah Almighty, would give them a sense of hope and help them to have a closure, a rational closure to what is it that they're dealing with, and how they're able to accept and move on in their life, knowing that there's a lot of reward for it, as the Hadith says, of a mom loses a child and will be the interceder for her in the hereafter in the Jannah, all the details. So these are things, of course, we're talking in brief because of the time limitation, but this is a very complicated process that needs an expertise to be able to walk the journey, of grieving further. And I love if I could use that. And I was the other day contrasting between what we do here in Canada and in the grieving process of lost a loved one. Most of the time it's a child or an adult that we deal with the family, and we have many members of different teams in hospital settings or community settings. Imagine what's it like to have a child with us who have lost 2 parents, 2 siblings, a leg, and have an infected wounds. May Allah have rahmah on them, and may Allah help us to be able to stand for justice. Thank you.
And the last section is just on postmortem autopsy, but I'll keep it brief and say that generally impermissible because the hadith essentially says that breaking the bone of the dead is similar to breaking the bone of the living, unless there's extenuating circumstances, in which case they become permissible. Go ahead.
I agree with you 100%, but I still believe that if medically needed, it should be done. And it should be done in a humane way. This is what I am in favor of. I'm in favor of doing autopsy, but in favor of doing that autopsy in a very humane way. I remember once when we had a child dying in the hospital, and then autopsy was needed, and then eventually when mom came to the process of ghusl, bathing, mom almost collapsed when she saw what they have done for her baby. So there has to be, and I've been speaking vocally and loudly about this, there has to be a different way, which I think right now is in the process of changing, to do autopsy in a more humane way that would help families to understand why their child died, to avoid a problem happening to them in the future. Because I've seen it with so many families. I've seen families walking through the doors of the hospital 2 times, 3 times, and living in denial. No, autopsy is going to be done to my child, and they're going through the same proven same process. So autopsy could be sometimes helping the family understand whether should they be planning for a child or not to have that, or whatever treatment needs to be done during the process of having children.
Absolutely. And from a medical perspective, what we'll generally recommend, especially to families that don't want to mutilate the body, is to take a skin biopsy. You can do a lot of things on skin, and you don't necessarily need, of course, if there was specific heart failure or specific organ damage, and you really wanted to test that organ or take a muscle biopsy or something, it may be better, but I always tell the families if they refuse autopsy, let us just take a skin biopsy, and this is for you. Because in the future, you can always grow that on fibroblasts and culture those cells and then expand the cell line. And that's usually more acceptable to families to offer a skin biopsy because it doesn't involve opening up the body. It can just kind of be done on the punch. And I tell clinicians, just take a skin biopsy. Especially with a baby that dies in the community, there's always usually some etiology. We can tend to find out what it is, especially with our technology now, but if we don't have tissue to sample, then we can't sample anything. So that brings us to the end of this talk, inshallah ta'ala. But we will move on, and if you have any questions, we'll kind of move on to our larger panel, so maybe just ask and hold your questions until then. And I wanted to invite both Dr. Asif Kabir and Sheikh Imran Ali to the stage, so we can expand to our larger Q&A panel with our esteemed guests, inshallah.
For the record, my practice outside, since I left the hospital, is ISIS.ca, and I deliberately mentioned ISIS so they can remember the economy. It's Al-Imam Family Services.ca.
Yeah, that and chair can go on that side. You did that for freedom.
One more